And we're back. We have Nicole and Marc Surdyka, the power couple that will actually be flipping the script. So Marc will be the interviewer today, and we'll be chatting about a relatively recent YouTube video and blog that we published on E3 and that I chipped away at for what felt like forever. And Nicole was a huge help with that editing process. And yeah, we're just going to dive right in. So Marc, do you want to, we can either provide a little bit more intro or we could just kind of go straight into the first conversation.
Yeah, let's do it. And we've been trying to make this podcast episode happen for a while. So glad we're all able to do it together. So the blog and the YouTube video that you created were titled ACL Reconstruction, Expectations versus Reality. And in them, you describe commonly held beliefs related to ACL surgery, the average rates of return to sport after surgery, and potential risk factors associated with a second injury. So we'll talk about what you found, and we have Nicole here for additional insight. As you said, she helped with edits on that blog and on that YouTube video, and she's worked with youth athletes and teams all the way up to professional athletes and organizations. So let's start, Chris. So prior to undergoing an ACL reconstruction, most athletes have certain expectations regarding their future level of function and their time to return to sport after surgery. So what are some of these commonly held beliefs and expectations?
Yeah, so I'll initially say that I wanted to create or write on this topic because this was coming up frequently in the clinic with certain patients that I was working with and treating, that we were already going through the ACL rehab process, and they were asking a lot of these questions. And one, I didn't really have a great resource to direct them to. And two, I didn't have a ton of certainty and confidence on answering some of those questions. So that's how I initially started wanting to dive into this topic and eventually write this blog. But what became very apparent in the research was there's still a lot of unknowns, and I'm almost less clear and certain than when we started. In this initial topic of commonly held beliefs, expectations, there was recurring themes in all these papers. There's three main ones that I kind of cited in the blog. And it was kind of a SparkNotes version. A lot of athletes believe that they're going to get back to either their same level of function or better in a relatively quick amount of time that was generally faster than what was described to them or expected of them. So a few papers that we cited was Fwecht et al. In 2016. All of the athletes expected a normal or near normal condition of their knee, and 2/3 expected to return to sport at the same level as prior to their injury without any restrictions. Webster et al. In 2019, 91% of the cohort expected to return to sport, and 84% expected to return to their same pre-injury level. They also go on to mention these expectations were lower on average in the second primary procedure, which just means an ACL reconstruction on the other knee, and revision groups, which is a second revision surgery on that initial injury, on that initial knee. And then the last paper, Armento et al. This group actually, in the study, they provided this kind of resource guide to adolescent athletes, 12 to 18 years old, laying out general expectations of the timeline and what to expect postoperatively. They said you should be out or expect to be out for a minimum of 6 months, but on average, return to sport clearance is between 9 to 12. Even within this information provided, the authors found that the majority of our adolescent population expected to return to sport after ACL reconstruction far sooner than the expected timelines, indicating potential unrealistic preoperative expectations. So I think wrapping it all up, there was very few papers that I found where there was a balance of appropriate expectations and understandings on timelines, what they objectively should probably reach and get back to, and the actual evidence for what are the true return to sport rates and what is the likelihood of them returning at their pre-injury level.
I think the study with the adolescent population is interesting, and it's kind of like drivers, right? Everyone thinks they're above average when it comes to driving, and maybe these athletes too, they hear these numbers and they say, well, I'm an above average athlete. I'm going to return to sport sooner. So, a follow up question for both of you. Do you think these high expectations, I don't know if I want to say they stem from this, but maybe they're not as realistic as we'll talk about shortly, based on the fact that how many of these athletes get told what rehab is actually going to look like? Like how intense rehab actually is over 9 to 12 months, how time intensive it is, not only in the clinic, but on their own, saying you're going to be doing quad sets all day long to try to get that knee straight. And you're going to be doing these exercises on your own time. Do you think that's a potential limitation with maybe not? That's maybe what I'm trying to say, like limiting those expectations.
Yeah, I'll go first, and then Nicole, I'm curious to hear your thoughts. Yes, I do. It's, I think, a combination of factors, but a lot of times the surgeons aren't really discussing any of the general timelines or criteria that should be hit along the way, or they're providing an arbitrary 6 months, you're cleared. There's that aspect. There's also the aspect of a lot of physical therapists aren't potentially informed on what they should be educating the athletes on regarding all of these factors. Or maybe the physical therapist is educated and informed, but these athletes aren't receiving preoperative rehabilitation. And there may not be that time period of setting those realistic expectations, having those conversations. And I think all of those factors lead up to this kind of mismatch. Also, there's the social media component, the general media component of these freak athletes getting back sooner. And that twists a lot of these beliefs. And I think more generally, that's common for a lot of surgeries and a lot of rehabs where people just expect they're going to beat the average. And a lot of times that's not the case. What are your thoughts, Nicole?
Yeah, I think a couple of things on this, like what Mark said in terms of the everyone thinks they're a better driver than they are. I think that's part of the issue with, that article that you cited in the video and the blog of even when the surgeon provided education ahead of time, it's general guidelines. Everyone believes they're going to be an outlier. Everyone believes, oh, well, if the average is a year, I'm an above average athlete, so I'll get back in half that time or in 8 months, whatever their belief might end up being. So I actually think that doing more individualized education, and within that, kind of what you touched on as well, Mark, what are the expectations of what rehab actually looks like? So making sure that that gets discussed in this individualized education, letting them know, forget about what's average. Let's talk about you, what you need to get back to, where you are right now. And then, especially in a population like the article cited, the adolescent athletes, especially for female adolescent athletes, rehab after an ACL reconstruction is often their first exposure to any kind of training, any kind of strength and conditioning, let alone rehab in the presence of an ACL injury. So tying all of those things together would just let an athlete know, hey, you haven't done a full S&C program before. We're going to be doing things you've never done before. This is hard work. Therefore, this is going to take longer than maybe what Adrian Peterson took or your favorite athlete took. So I think that those might be some keys to helping to make some more realistic expectations.
So, Chris, these athletes have these high expectations, but what are the actual return to sport rates?
Yeah, the main one that a lot of people cite, and I think is the most well thought of, is I think Claire Ardern ended up having 2 systematic reviews, and they were similar numbers, but we cited the one in 2014 looking at these return to sport rates, and it's on average about 80% of individuals will return to some level of sport. That is not their pre-injury level. So they go on to state that 65% return to their pre-injury and 55% return to competitive level. There was a little bit of confusion when I was reading that of what true competitive level of sport is versus pre-injury. And they didn't really identify the difference, from my understanding, what I guess was, for some people, their pre-injury level of sport could have been just a recreational level. And so if you're returning and you played recreational and you're returning back to recreational, maybe that's what it was characterized as and why that competitive level percentage is lower. There was another group by Webster et al. They also say that roughly mid 80% of athletes return back at the same pre-injury level. And then they said only 24% actually met that expectation at the 12-month mark. So yeah, it's a relatively high number will return, but there's a significantly lower number that will match that pre-injury level that they were probably hoping to actually return back to.
Yeah, so there's a bit of a mismatch between expectations and reality, which is the title of the blog and the YouTube video, in that these athletes are assuming that they're going to have really high functioning knees and just overall bodies right after an ACL reconstruction, but maybe they're not getting back to what they were doing. Nicole, do you have a different interpretation of what those numbers mean? Meaning like some type of sport pre-injury level versus competitive sport, or is it, as Chris said?
Yeah, I mean, I think for those types of studies, it's nice to have that big data set of a heterogeneous group of athletes. So the cohort is very heterogeneous in that there's some high school level, some college level, male, female, elite, non-elite, amateur, recreation, all of that, because it just gives us as practitioners a general sense of setting our expectations for working in a standard outpatient clinic. But I do think that it's helpful to dive a little bit deeper into the specific population in which you're working. So, for example, in a professional setting, a professional team, they're more than likely going to come back to their same level. It might take them a year extra to get back to their performance levels, but more often than not, they're coming back after an ACL injury. But we also have to think about the athlete, what the athlete would do regardless of this injury. So I've worked with a number of high school seniors who had no intention of playing in college and get an ACL injury their junior or senior year of high school and don't come back. Now that would contribute to that low number of return to same level cited in these studies, but maybe they had no intention anyway of doing that. And so that skews the numbers a little bit. So I do think we have to, if there were studies that broke down the population a little bit more specifically and had more homogeneous populations within their cohorts, I think that would be helpful. But then it's hard to get the sheer number that you need to have meaningful data. So I would just say to practitioners, take that information and use it, but use it with a pinch of salt.
Gotcha. So I guess to your point too, Chris, my interpretation of that is some sport could mean, let's say it's a soccer player. Some sport means like, depends on how they define sport too, right? Maybe someone defines sport as cycling on the weekends and they're just doing some level of activity there. Like you said, pre-injury level of sport, maybe they're going back to playing soccer and pickup games versus competitive level. They're going and playing for their high school team or college team. And even then, this is to Nicole's point, there's even more to pick out there because maybe they're playing at their pre-injury level or the competitive level, but are they running as fast? Are they cutting as well? Are they scoring as many goals? Are they getting as many minutes of play time, right? Like, are they at their competitive level, but now they're on the bench rather than playing as much as they did? So there's a lot to pick out there and a lot of unknowns. So this is probably a question that most people who go on to get an ACL reconstruction or plan on getting an ACL reconstruction want to know is, what are the chances of a second ACL injury, either to the same knee, so the knee that was injured and had the surgery, or to the other knee?
This, I think we can also have a similar kind of caveat that Nicole just mentioned here with what I'm about to cite, where these numbers are in more heterogeneous kind of groups. And if there is research for more specific sports or levels of sport, we should probably use that when having these specific discussions with our athletes. But the two papers that we discuss were two systematic reviews. One was by Barbara Weston et al. In 2020. They said, although roughly 80% of athletes post ACL reconstruction return to some level of sport, 1 in 5 athletes sustained a re-injury to either knee. The other systematic review was a little bit older, Wiggins et al. In 2016. The incidence of re-injury in young patients less than 20 to 25 years old who returned to high-risk sport was 23%. This means that nearly 1 in 4 young athletic patients who sustain an ACL injury and return to high-risk sport will go on to sustain another ACL injury at some point in their career, and they will likely sustain it early in the return to play period. Should we discuss or kind of define what high-risk sport is now? I know I mentioned it later in the blog. That may be helpful because it was just brought up.
Yeah, go for it.
So high-risk sport is essentially any sport that's classified as having a high level of pivoting, cutting, change of direction. They'll classify basketball, football, soccer, I believe skiing into high-risk sport. And that's how generally they'll clump when they say high-risk sport, those specific sports. Nicole, do you have any other thing to add with Mark's initial question?
Yeah, I do have a couple things to talk about on this topic in terms of right now. I kind of wanted to let you go a little bit more with some stuff from the blog and the video. But in terms of I think you did a really good job in the video and blog of stating and making the point that it's that level 1 sport that's the risk, right? Like returning to that is the risk. So I'll just briefly say, like a couple of years ago, a study came out. I think it was Webster and Hewitt saying that athletes who pass all return to sport criteria are more likely to have a second ACL injury. And this is where interpretation is so important, because people saw that and said, oh, no reason to do return to sport testing then. I knew it all along. Those tests don't tell us anything. But really, let's take a look at what it actually means is people who pass return to sport testing are likely the ones who go back to return to sport, which is the risk. That's like saying people who pass their driver's test are more likely to cause a car crash. Yes, because they're the ones who are out there driving and behind the wheel. So I think that point is the point to make here, that level 1 sport is the risk. So when you go back to that, now younger athletes tend to go back to that. And you brought up some of those other caveats in the video and the article that I'll let you touch on more. But at the end of the day, it's the level 1 sport.
So just to provide some clarity too, because we've used two different terms or phrases, but we're using high-risk sport and level 1 sport somewhat synonymously. And these papers will describe, as Chris said, this is a level 1 sport, the soccer, football, basketball, and then maybe a list of level 2 sports or level 3 sports. Maybe my example of cycling earlier wasn't the best, right? It would be if someone was playing soccer, some level of sport, maybe they're returning to something that's level 2, level 3. Our favorite example is pickleball. Maybe they're returning to pickleball. So anyway, Chris, what factors increase the chance of a second ACL injury? And you created a list and talked through this list. So maybe let's go one by one and work through that list.
Sure. Nicole already alluded to it, but the primary risk factor is returning to level 1 sports. And we'll dive into it later. But we'll start there. Why is level 1 considered the highest risk factor? There's another risk factor that I think I'm going to bring up when, Mark, you have a later question of like anything I would add or change to the blog or YouTube video. So I want to circle back to another risk factor that may be even higher. But return to level 1 sports, what we do know with ACL injuries is they generally occur at certain positions that the lower extremity is in, with the hip, the knee, the ankle, the trunk. There's a variety that an athlete can be in, and those positions at high forces high velocities, and generally when someone is decelerating or trying to brake, those are generally the positions and the forces that set someone up for an ACL tear. Those positions and forces are very common in sport, especially level 1 sport. The demands of cutting, sprinting, blocking, decelerating, change direction, your general volumes, frequencies, and exposures is significantly higher when you're going back to those sports than less chaotic and demanding activities like, jogging or, bicycling or not participating in sports. So that's why level 1 sports is considered one of the highest risk factors, because it's setting you constantly up in those positions that your body's in, which I can name a few. So the joint angles that are commonly described are shallow knee and hip flexion, internal tibial rotation and forward translation, knee valgus, and lateral trunk and knee abduction. It's kind of a combination of those activities or those positions during a deceleration or slowing down based activity or task, or with like a direct contact or collision to another athlete. So that's why generally it's assumed or stated that level 1 sport is the highest risk factor. Some of the quotes that we found or that we mentioned was Cronstrom et al. 2021. This was a systematic review. They said that return to high activity level was the most prominent risk factor for sustaining a contralateral second ACL injury, just meaning injury of the ACL to the other knee. And then the Delaware Oslo ACL cohort study by Grindam et al., they also mentioned that the knee re-injury rate was over 4 times higher in ACL reconstructed patients who returned to level 1 sports after surgery compared to those who did not return. So I'll stop there. Nicole, you have any thoughts with return to level 1 sports?
Yeah, I mean, I think you said it perfectly. It's what causes an ACL to tear, and you talked about the position that's cited in the literature, and what activities put you in that position more often under high stress and high load. It's level 1 sports. So that is why that is a risk factor.
I'll go. Mark, you have anything, or do you want me to go straight into 2?
I think actually coming back to 2 and talking about age, because age really builds off of this. So talk to us about age.
Yeah, so what was common in the literature, some of the studies that I already mentioned, they also included the ages that people are at higher risks of a second ACL injury. So Barber Weston et al. In 2020, they said that a high rate of athletes less than 20 years old returned to sport, but 1 in 5 suffered re-injuries to either knee. And the majority of these occurred during high-risk sports. And there were a few other papers, but they all mention this younger age. And what we provide caveat is that age in and of itself is not the risk factor. It's those people that are younger are most likely to return to level 1 sport, whether it's a high school athlete, a college athlete. If someone's tearing their ACL in their, late 20s, 30s, 40s, they may not return to high level activity or much activity at all. So the age component, it's not because you're 18 years old, it's because you're most likely going to continue or to re-engage in high-risk activities.
Exactly. And I think that's a great point to make it, because again, when those studies were first coming out, it was, oh my gosh, protect the younger athletes, they're at higher risk, and really dive into it a little bit more, think about it a little more critically, like you just said. And I'll use myself as an example. When I was 20 and playing college soccer, if I tore my ACL, I'm going to try to get back to playing college soccer. I'm 36 now. I sometimes will play a pickup soccer game here or there. I haven't done it in a while, but potentially something I would do. If I was to tear my ACL, I would no longer be going and playing pickup soccer games. So I'm not returning to that sport at this age, whereas same person, like same human being here, but me 15, 16 years ago, I would have. So that's where age becomes part of the risk factor, but it's just a proxy for returning to level 1 sport.
We kind of jumped right into the topic today, but for everyone listening, Nicole did play Division I soccer, so she does have that experience and the experience as a clinician. How about early return to sport, Chris, and defining early? Is there a definition of early?
Yeah, my understanding of a definition of early is less than 9 months. A few papers suggest that waiting 9 months or greater can set yourself up to have a lower likelihood of a second injury. One of them was Grindam et al. In 2016. During the first 9 months after surgery, a later return to sport was significantly associated with a lower re-injury rate. For every month of delay in return to sport, the re-injury rate was reduced by 51%. Patients who participated in level 1 sport earlier than 9 months after surgery sustained 39.5% re-injuries compared to 19.4% knee re-injuries in those who returned to level 1 sport later than 9 months. The other one, actually we had two others, Beischer et al. Or Beischer et al. In 2020, athletes who had returned before 9 months after reconstruction had an approximately 7-fold higher rate of second ACL injury compared with those who returned at 9 months or later. Grindam et al. Mentions the increased risk could be due to insufficient biological healing, graft incorporation and remodeling, incomplete rehabilitation, or both. Those are the two commonly stated kind of rationale or explanations for why someone should wait at least 9 months. The incorporation and maturation of the graft and the tissues as a whole, and the what we had already mentioned, just the lengthy nature of return to sport and preparation, and that is a multiple month or potentially a year plus long process. So those are the two that they mentioned. I don't know, Nicole, if you have any other thoughts, but 9 months or earlier is what is described. Earlier than 9 months, sorry, is what's described as an early return.
Yeah, and this comes up a lot because this is important in what the theme is, setting expectations, right? And creating those expectations before surgery happens, ideally. And this is another thing where I'm going to say that population and cohort matters. And so that Delaware Oslo cohort, again, high school to high school age, all the way up to in their late 20s, early 30s or so, kind of run the gamut in terms of level of activity at time of injury and getting back into activity after their injury. And so I would say, general rule of thumb, if I'm working with a youth athlete, especially I tend to work with teenage female soccer players, they're waiting minimum 9 months, usually a year. I start off the bat by telling them we're looking at a year-long process here. Professional athletes, and this is where, again, you have to be population specific, because I'm not saying that they should return before 9 months. I don't think I'd ever straight up recommend that. But I think setting a timeline is always important for expectations, but setting the objective criteria is far more important, and showing them what they're going to have to be able to achieve. And this works across the board with every patient. But what is it that you have to do in order to be ready to play your sport again? Not how long is it going to take, because how long it takes can vary. When you're working in a pro team setting, you have them every day for the entire year. That's their full-time job, is to rehab. So if they hit those objective criteria, and I've worked with a professional male soccer player who came back in 6 months and is doing phenomenally. Now, he's an outlier for sure, and that's never going to be across the board to anyone else I work with. I will probably never work with someone like that again. But never just saying like this is the rule, but these are the objective criteria you have to hit. And my 15-year-old high school athlete, this might take you a year or more, because you have school, you have an after-school job, you have siblings, you have parents who work all day, and it's just hard to find the consistency in your rehab. So that's where I think the timeline, it's nice to give them that, but when we're educating and setting expectations, there has to be the description of why it takes that long, and that you have to hit these markers objectively to continue on.
That's a great point. And you might tell a professional athlete, rehab is going to take 9 months or longer. And that professional athlete might come back and say, well, I need to be ready in 8 months because that's when playoffs are happening. And not that we want to change how we practice based on who we're working with or based on pressure that we're receiving from external sources, but you always have to take those preferences and considerations into mind. What are your thoughts on, there's a paper 2017, should return to sport be delayed until 2 years after ACL reconstruction, biological and functional considerations? And this is by Christopher Nageli and Tim Hewitt. Is that great? Yeah, 2 years sounds nice. That's great for your health. But for someone who's a competitive athlete, is that just a career killer?
I'll let Nicole lead with this one. She probably has more thoughts than I
No
do.
problem. Yeah, so I've actually heard Tim Hewitt speak about this paper and present on it. And he actually meant this paper as kind of tongue in cheek. Like, if we are only going to rely on biological tissue healing, then yeah, we should say 2 years, because that's when true ligamentization of the graft happens. If you're using a patella tendon as your graft, changing the actual fibers of a tendon into a ligament takes 2 years. And so that's where, again, it's kind of satirical or tongue in cheek, like, oh, we should wait 2 years then. Nobody has that expectation. Nobody's going to wait 2 years. And even if you did, you would still need a rehab program during that time to make your tissues adapt. So no, I don't think anyone should wait 2 years. That should never be the expectation. But it's a way of showing and driving home the fact that biological healing doesn't actually this is not a native ACL. This is not even a true ligament until 2 years on. So that makes hitting the objective criteria all the more important.
Nothing to add there. Nicole crushed it.
Okay. How about female sex?
Again, Nicole's going to have way more of an elaborative response on this. And we had an earlier podcast that Nicole discussed this exact topic. I think it was 2, 3, 4 years ago when it came out. But female sex from a re-injury standpoint is not considered a significant risk factor compared to males. So Patel et al. In 2021, they state the results of this systematic review and primary meta-analysis determined that there is a negligible, non-statistically significant difference in the relative and absolute risk of experiencing a second ACL injury between both sexes. Stated more simply, males and females display similar chances of second ACL injury, both groups with over a 20% risk of re-injury. The other paper I mentioned was Hughen et al. In 2015. Although a strong predictor of native ACL injury, female sex was not found to be a risk factor for tear of an ACL graft. So my understanding is a second injury or a re-injury, females are not at a higher risk. Nicole, can you maybe provide some input as why females may be at a higher chance of an initial ACL injury?
Yeah, so I was gonna lead with, I think that this is one that probably shocks a lot of people when they first hear it, that being female makes no difference for a second ACL risk. Now, of course, it does matter right now. Based on the literature, female athletes are anywhere from, depending on which one you read, 3 to 6 times or 3 to even 8 times more likely to tear their ACL than male athletes. And oh gosh, I could talk for hours about why that is. I won't do that today. But basically, it can be summed up into both sex and gender-based differences, and some of those things being modifiable risk factors, and some are not modifiable risk factors. And we're still getting at the heart of this and still don't have a true good reason why this is. My own experience, and both as an athlete, as a female athlete, and also as a clinician, is that I think that a lot of female athletes, and that's where this stat of it doesn't affect their risk of a second injury, to me, I flip that and say, okay, so if there's no greater risk, what are they doing? So they're rehabbing probably about the same as male athletes, right? So female and male athlete tear their ACL. They're rehabbing it and trying to meet the same goals and objective criteria, regardless of their sex or gender. Now, that male athlete probably had some level of a strength and conditioning program or went to the gym with his buddies or teammates had some level of, or a larger training age than that female athlete before her injury. So to me, I flipped that script to say, well, if there's no increased risk after the first injury, why is there an increased risk for the first injury? Maybe it has a lot to do with training age and exposure to a good holistic strength and conditioning program, how long they've been training for before this initial injury. I mentioned before, most female athletes who are teenagers and tear their ACL, that's their first exposure to an S&C program is their ACL rehab. So if we can put that on the front end and expose them to that for a longer time period before the injury, maybe those initial injury rates will actually drop.
Yeah, there's been such a big emphasis on biological or anatomical differences, and a lot of those have been kind of debunked anyway. And the question you might ask is, if there are differences or other differences, but they're non-modifiable, what's the point in stressing about those differences versus something like exposure to training is very modifiable, easily implemented, and you could do that on a very wide scale pretty easily. Okay, how about graft type? Allograft versus autograft. Chris, define the difference between those two and then expand on it even more.
Yeah, so an allograft is a graft pulled from a cadaver, so not someone's actual body. A autograft is pulled from that individual's body. So there's a variety of autografts. Nicole, I think, already mentioned one. There's now, I would say, 3 general common ones, but 2 are the most prevalent. The bone patellar tendon bone. There's the hamstring tendon, and then more commonly now is the quadriceps tendon. There's other autografts or other tissues that are used, but I would say those 2 or 3, the hamstring, the bone patellar tendon bone, and the quadriceps tendon are the 3 most common. From an allograft, the graft that's taken from a cadaver, not the human, there's generally a higher risk of re-tear. There's reported to have higher re-rupture rates. Wasserstein et al. In 2015, in their systematic review, they looked at and compared allografts versus autografts, and individuals that had the allograft had higher re-rupture rates. Looking at autograft differences, at least the 3 big ones, hamstring, bone patellar tendon bone, and quad tendon, there is multiple systematic reviews and meta-analyses that suggest that there's similar rates of second injury, and there's not a major difference between those 3. There's other papers that do say that, hamstring is superior or bone patellar tendon bone, but when I was kind of zooming out, I think big picture, there's not a big enough difference for me to have said that absolutely this is the superior autograft. Nicole, would you generally agree with that? I know some surgeons have their preference, and I think the recommendation that I ended up making was whatever the surgeon that you decide to work with is, whatever their preference is, the autograft of choice, whatever they were trained in, whatever they use the most, that's probably the one you should choose. That was my kind of ultimate recommendation out of the autografts themselves. But Nicole, what are your thoughts there?
Can I do a follow-up question, and then
Sure.
Nicole, you can answer both, and Chris, you can answer? Because that was a question I was going to ask, is pre-surgery, do patients ask you for recommendations? I know, as someone who works a lot with patients who are going to get total hip replacements, they'll ask me, should I do anterior approach, posterior approach? What kind of prosthetic should I get? And then sometimes even afterward, if their function, like let's say I see somebody who I've never seen before a year or 2 after their surgery, and their symptoms and function aren't where they want it to be, they'll say, I got the anterior approach, I should have gotten the posterior approach. That would have been a better approach for me, and that's the reason why things aren't going well. So you can answer that, I guess, Nicole, is, do you ever have patients pre-surgery ask you, tell me what to get, or say, tell me what to get? Do you give a recommendation, or do you say, these are the 3 surgeons that I like? These 2 have the same approach. This one has a different approach than these other 2. From my experience, from what I know from their outcomes, they all have similar outcomes. So maybe choose the person who you trust the most and get along with the best.
Yeah, I would say, and Mark, you say this a lot, is whatever the surgeon is most comfortable with and usually does. I will say, I know most surgeons keep their own stats of their failure rates for surgeries, for ACL specifically. So they know if they spent the first 10 years of their career doing all hamstring autografts, they know what their failure rates. Now, of course, those numbers have to be taken with a pinch of salt, because if the athlete doesn't come back to them, then they don't get that stat. But they know over the years, the good surgeons, what grafts work best for them based on how they perform surgery, the types of patients that they work with, etc. So find a surgeon and let them make the decision on the surgery. That's their bread and butter. That's what they're good at, and the good ones know what work best. So that's always the recommendation I say. I say, here's some, like you said, Mark, here's 3 really great surgeons who I've worked with and who I trust. Because also you have to take into consideration, it's very rare that somebody just tears their ACL in isolation. There's usually always some type of concomitant injury, and you want a surgeon who's going to look at the whole knee and the whole athlete to make the best decision. Because maybe in 10 years we're going to look back at data and say, oh, quad tendon autograft, which is still coming into popularity right now, that has the best rates by far. But maybe for specific athletes who also have some medial knee instability or also have some rotational instability that needs to be addressed somehow, maybe that ends up not being the best choice for that subset of the population. So again, all that to say, there's always concomitant injuries. Every individual needs their own individual treatment program. And so getting the best surgeon you can is far more important than getting a specific graft. Now, going on from that, there are, of course, pros and cons to every type of autograft. I think things we've probably all seen is a patella tendon. Sometimes athletes end up having patella tendon pain, patella tendinopathy-like symptoms. Now, if your loading program is good through rehab, you can address that and get away from that. And so not something that would make you choose or not choose that, just something to be aware of. Similar with hamstring tendons. They tend to look really good really early, which then maybe makes them go back to sport a little too early. And so there has to be that caveat of slowing those hamstring autograft patients down a little bit because they feel really good and you feel like they can fly through. Also coming into popularity right now are the extra-articular procedures. So lateral extra-articular tenodesis, or the LET procedure, is becoming more and more popular, especially to add. So anytime you add an extra-articular component to the surgery, you're addressing the rotational instability. So some athletes might need that, some might not. So again, all that to say, choose your surgeon, not your surgery.
Anything to add there, Chris?
To your question of have I had athletes ask what I would choose, it was actually my first ever patient that tore his ACL. He was 7th grade, super young, and he had one surgeon recommending kind of an IT band procedure. One was recommending a hamstring. Him and his mom were super anxious and concerned, and I was my first patient with an ACL reconstruction or about to receive one, so I didn't have a ton of input in the matter, but I generally said, based off of your rapport and your communication with each surgeon, I would choose the one that you feel the most comfortable with, that's provided the most information to you, and they ended up choosing a hamstring. But between now and then, there haven't been a ton that have asked me. A lot of them have already received the surgery, and I'm seeing them post-operatively. Yeah, I think that's all I would add.
I do want to state that when we say find the best surgeon, we don't mean fly across the country or fly across the world. There are tons of very good, competent surgeons all over the world who don't have a social media page, who don't work for a professional team. So take the phrase, best surgeon with a pinch of salt there. Okay, Chris, how about quadriceps strength and return to sport testing?
Yeah, this one I think is where I still have a lot of uncertainty. And Nicole, I'm curious to hear your thoughts, but there was a variety of papers suggesting that quadriceps strength and return to sport testing was a protective factor and reduced the risk, and there was others that said the opposite. To the latter point, I think some of that is what Nicole had mentioned earlier on in this episode, is people that reach certain milestones and objective criteria, it may show that they are at a higher risk, but it's because they were actually able to return back to the level one sport. So I'll give that caveat, but I'll provide a few quotes and a few papers, and then I want to hear Nicole's thoughts. Lochial et al. In 2019, passing return to sport criteria did not show a statistically significant association with a risk of second injury, ACL injury. The quality of evidence ratings prevents a definitive conclusion on this question and indicates an opportunity for future research. Webster et al. In 2019, passing return to sport test batteries did not significantly reduce the risk of further knee re-injuries, injuries in general, or ACL injuries specifically. Welling et al. In 2020 reports that passing return to sport tests can increase the chances of return to sport, but does not determine the likelihood of secondary ACL injuries. And then I mentioned in the blog and in the YouTube video, there are a handful of papers that provide the opposite claim. So Grindham et al. In 2016 argues for the importance of assessing quad strength as a key factor for determining risk of second ACL injuries. And then I had mentioned that there was Kaplan et al., a group that kind of counteracted or critiqued the claims by Webster et al. That was saying that quadriceps strength and return to sport test batteries were not a like helpful factor in reducing the risk. So I still don't have a ton of certainty on one way or the other. And then our conversation with Rula Katsufaki about a year ago, she was one of the lead authors on the most recent ACL Reconstruction clinical practice guideline, their group based out of Aspetar. Their statement or beliefs is, quote, currently it is not clear if passing a battery of tests is associated with lower risk of second ACL injury. And then they add, despite this caveat, we maintain that our clinical goals should be to restore all impairments and return the athlete back to their previous status, if not better. At this point, I lean towards that latter aspect of, I do believe that returning the qualities that are necessary for the demands of someone's sport that they have to get back to, and finding tests that constrain someone enough to find a potential discrepancy is valuable. But my certainty as if they hit this specific number or close this specific deficit, that they will have a significantly higher chance of reducing a second injury, it's a little bit lower. I liked when we had Scott Morrison on, his kind of conversation around probabilities of, if we're checking a lot of these boxes and we're moving the needle forward in a lot of these objective testing that we do perform, quadricep strength testing, hamstring, vertical jump, counter movement jump, if those are getting closer and closer to the metrics that are in the research, and it's improving also close to the other limb or to someone's body weight, whatever it is, our probabilities of reducing a second injury, or our likelihood, is probably better. So I like the probability aspect, and I like the conversation around, from a performance standpoint, this is also some of the criteria. But from a true risk reduction, I think there's still probably more uncertainty there. I'll stop there. Nicole, what are your thoughts with it?
Yeah, so in terms of the quad strength and isolation, or any objective metric we're going to look at, the question we have to always start with isn't what is your strength, it's why are we assessing this? What is the purpose in assessing this thing? And in the case of somebody coming back from an ACL reconstruction, it's, what is your knee like? Is your knee healthy enough to do this? Can your knee, after this injury and surgery, tolerate the demands that you want to go place on it now? And all of these tests and measures that we do are simply proxies for determining is the knee prepared for this? And so that's why you touched on beautifully there that quad strength, if they have increased quad strength, they pass the return to sport battery, they go back to level one sport, thereby increasing their risk. I would also say there's athletes who are really strong, go back to sport, and guess what? The really strong athletes put a lot of load through their knee because they produce a lot more force that they now have to brake against or decelerate against and put themselves at a risk of an ACL injury, right? So strength alone it is of course protective against all injuries. We know that from general injury prevention programs that building good strength is a good protective mechanism for all lower extremity injuries. But after an ACL reconstruction, yeah, there's conflicting evidence because we're trying to look at it as this, here, you need this cutoff score, and now all of a sudden you're ready. And we have to look at the whole human, the whole person. And again, why are we testing this? What is this telling us? So the better thing to say is, what do we need to know? What does this athlete need to be able to do? Can we test those specific things? If so, how? And how do we test that consistently across the program? So our return to test batteries, I think, just aren't specific enough because we try to say, and again, it's helpful, we try to say, okay, across the board for this heterogeneous population, these are the 5 tests that every clinician should do with all of their patients after an ACL reconstruction. And that's helpful, but not going to be the answer for every single person you work with and for every single clinician. Find what does that individual have to do, determine how you can assess that, and then take that into consideration with the whole person. That's what the START framework is really helpful for. It takes the local tissue things, then the whole body factors with the person and the activity level, and then the risk modifiers.
I think you both bring up really good points. I'm thankful that I'm too unathletic to tear my ACL, to Nicole's point. I like Chris's discussion of the probability because we can have that discussion with patients, right? Of saying our intention with having you pass these return to sport testing criteria is to best prepare you for your demands of sport. But there is still some uncertainty about whether or not you are completely risk-free in terms of re-injury. And obviously that doesn't exist, right? There's no bulletproof, there's no risk-free guarantee with sports. So we're saying we're trying to increase those probabilities that you're not going to get re-injured, but having that discussion too, that sport is so multifactorial that we can't account for every possible factor at any single second in time, with whatever they're doing. The other thing too, not just speaking to the research, but just in clinical practice in general, is that return to sport testing is not standardized, which makes it a little bit more difficult. I've made a video kind of critiquing somebody else's video who said, hey, isokinetic dynamometers are kind of outdated and overrated, and instead you should do these things, right? So as a profession, we still struggle with the standardization of these return to sport testing. And the better standardization we have, whether or not they reduce the risk of injury, fine, but that at least allows us to research the topic better by having some of that standardization. So all that to say, can you actually prevent a second ACL injury? And if not, how would you best prepare an athlete looking to return to sport?
No, you cannot definitively prevent a second ACL injury, or most likely any injury for that matter. What I outlined in the blog and in the video were 5 primary things. There's other things someone could list in here, but these were the 5 big rocks that I wanted to prioritize. 1, wait at least 9 months for a full return. 2, complete a progressive and adequately demanding rehab and training program during these 9+ months. 3, frequently assess the limb and entire athlete's capacities and qualities necessary for successful performance through a battery of return to sport tests. 4, complete a graded return to practice, sport, and competition-based program. And number 5, demonstrate psychological preparedness and confidence for a full return back to sport. And I think those 5 are valuable in the sense that there's not one that's the magic pill. It's a combination of all of these factors. There is a time component. There's a ton of physical capacity components. There's a psychological and mental component. There's a graded return and confidence in the skills and the sport itself. All of these things mixed together to provide more clarity on the readiness for someone's return. And I think all of them should be considered, and they're all super valuable. Those are the things that are probably going to help us reduce the likelihood of a second injury. If all of those were ideal, there's still a chance that someone could re-tear, and that caveat needs to be there because there's so much chaos and complexity and external factors that are out of our control with returning to sport, that all these things could be great. And then a quarterback gets smashed by their O lineman that lands on their knee and they re-tear. There's no way you could potentially prevent that. So those caveats need to be there, but the things that are within our control and within the athlete's control, those are the 5 that I think are really important. Nicole, do you have anything else to add with those 5?
Yeah, I think those 5 are great. I would say one thing that I think about, well, first of all, I'll say you can prevent another ACL injury, and that's by just not doing sports anymore. Like, just won't do risky activities and you won't tear your ACL. But assuming that's not what our patients want and they want to get back to sport, I think the 5 you lay out are great. My only thing that I would add is we need, and you said this, frequently assess. I think I want to drive that point home because too many clinicians, from my own experience, I think, and too many athletes believe they're, okay, here's my testing day at 9 months. If I pass, it's go. If I don't, it's no go. And one day of testing is not enough to make a decision like that. We need to have multiple data points and take the whole athlete into consideration, and not just the athlete, the context of their environment, their social structures, their team environment, all of those things. So for this type of thing, I like looking at the START framework that I mentioned earlier to help with these decisions, but I would say serial testing, get as many data points as possible.
Chris, I have 2 more questions. Oh, go ahead.
I want to add something. So it's sad, but it's also wild. There was an individual that was in our clinic that had torn his ACL twice. He didn't want to play in college, went to college, joined a fraternity. Apparently one night some stuff happened. He fell down the stairs, retore a 3rd time. So sometimes even if someone doesn't go back to sport, there's chaos that happens in someone's life, regardless of the sporting aspect.
Very true.
Yeah.
Yeah. Nicole and I have actually had a joint patient experience where, like, I saw this person for a while and I thought, you know what, I think she would do really well with Nicole. And then Nicole saw her. And then, she did have multiple injuries, multiple surgeries, and just recently reached back out to Nicole to say, or maybe we ran into her on the street just to say, my knee is doing great. And we hadn't, saw this person in years, which was nice to hear. So I do have 2 follow-up questions, but can you summarize everything we've discussed up to this point?
Sure. So starting off with expectations versus reality, kind of the name of the blog and the YouTube video, a lot of times there's a lot of high patient expectations going into the procedure and during the rehab itself. Those expectations commonly aren't matching reality. Number 2, about 2/3 of people will return to some level of sport and to their prior level, but only half return to a competitive level. Number 3, on average, 20 to 30% of athletes return to sport will suffer a second ACL injury. Number 4, returning to level 1 sport is the strongest predictor of experiencing a second ACL injury. 5, younger populations are at elevated risks due to the nature of this group having the largest probability of returning back to level 1 sport, not their young age in and of itself. Female sex is not a risk factor for a second ACL injury. 7, allografts compared to autografts demonstrate larger rates of re-rupture and second ACL injury. autografts, the three we mentioned, quadriceps tendon, hamstring tendon, bone, patellar tendon, bone, are relatively similar in their kind of re-rupture rates. And going back to the surgeon that you feel the most comfortable with, the autograft that they feel the most comfortable and confident with should be the priority. 8, a battery of return to sport testing does have some mixed results in regards to the reducing the likelihood of a second ACL injury. However, frequent objective testing should be used throughout the rehab process to determine the readiness and progression and guide decision making. Those are the 8 kind of key summary points there.
And after having this conversation, reflecting on the topic after a few months have passed now, is there anything else that you would add?
Yeah, I thought about this almost immediately after we published it, and I don't know whether or not it should have been included, but potentially a higher risk factor than just returning to level 1 sport is the prior injury history. Injuring it the first time. I think the reason I didn't include it was because it is non-modifiable. There's nothing that we can really change there. It didn't really have any actionable information, but I think it would have been worthwhile to at least touch on a lot of injuries, most injuries. The thing setting you up for the likelihood of an injury is a prior history of that injury. So second tear, the strongest risk factor potentially is the initial tear. So I think maybe touching on that could have been worthwhile, as opposed to just saying return to level 1 sport is the primary risk factor. That was one. I have a few other thoughts, but Nicole or Mark, do you all have anything to add to that point? Do you think I should have
I
added
was going
that?
to say, I think that's a really empowering message for people who've had an ACL reconstruction, even though it seems counterintuitive that it's empowering, because like you said, the number one risk factor for every injury is a history of that injury. Number one risk factor for hamstring strain is previous hamstring strain, and the re-injury rates in some injuries are higher than the re-injury rates for ACL injuries. So I think that's kind of an empowering message, and maybe a twisted way is anyone who's had an injury has an increased risk of that injury. You're not alone. It's not something unique about ACL injuries. It's across the board.
And it's, to that point, it's no longer a blind spot. You know that, and you can emphasize the importance of this rehab and return to sport process.
Yeah, another thing that I don't know if I would have included in this piece, it could have maybe fit, but something that's come up in the clinic with a few patients that I've worked with that have been a little bit older and were considering whether or not to receive an ACL reconstruction was this resource I found through, I think I just found it randomly on Twitter, but it's by Stephanie Philbay's group out of University of Melbourne, but it's a website, ACL Injury Treatment Decision Aid. We can link it, but it's been phenomenal resource to have athletes or patients fill out. And it's kind of a 5-step guide or process of introduction to an ACL injury, learning about their treatment options. How do these options compare? Weighing up the pros and cons. What are, the risks and benefits of non-operative management versus operative, and then kind of filling out a decision like form, or like, where do you stand on the spectrum of the things that matter to you? And I've had multiple conversations with patients where I say, hey, before I see you next, I would love for you to look into this and we can discuss it when you come back in. And there's been a few middle-aged patients where they ended up realizing, oh, wow, there's a lot more there of the pros of non-operative management. I think I want to go down this path. And we discuss, there's uncertainties with both options, but I think it's worth a shot for XYZ reasons. And for what you're telling me is what you prioritize. So from an overall just discussion with patients with ACL injuries, I think that decision aid has been super valuable. And there's a lot more of these decision aids coming out. And it seems to be out of Australia. They're freaking crushing it. But that one in particular, I think is laid out very well. It's aesthetic, and I think it's helpful for patients and clinicians to work through together. Any thoughts there?
Yeah, I like the decision aid. I think I've brought this up probably a long time ago, but I remember seeing a patient who was probably in her 50s, maybe even early 60s, who tweaked her knee as she was putting luggage in the overhead compartment on the plane, went and got an MRI, and ended up getting an ACL reconstruction, which, if she had read the decision aid, would realize that probably unnecessary. So I've had a lot of experience with this process, and Nicole has had some recent experience with this as well. But for you, Chris, how was the process of writing this blog and turning it into a YouTube video?
It was a journey. I think it was a little bit smoother than the first one I worked on, the fibromyalgia piece, which was a brutal decision to write that because there's way more gray in fibromyalgia, I would say, than ACL world. But I would say it's great going through this process and kind of stumbling my way through. And I'm so thankful for you, Mark, and you, Nicole, for providing feedback, kind of being mentors throughout this process, because there's so many ways to try to interpret the research landscape and to provide clinical real world expertise, and then to make it format in a way that patients and athletes can actually find this useful and valuable, and not just have it be a super either clinician oriented guide or just be so sterile that it's not impactful. And so writing it in and of itself is really tough, and coming to the conclusions that we tried to make while providing the caveats of the uncertainties, and then trying to reformat that into a video. And then just the nature of trying to talk on camera is extremely anxiety inducing. So the whole process, I think it was a great learning. And like we've talked about privately, just writing more, reading more, and then trying to talk more. The skill, getting better at something is, you have to do the thing more to get better at it, and you have to stumble your way through. So that was my general thoughts on this, that for my second long piece, I'm happy with how it turned out. And a lot of it was because y'all were able to kind of provide lanes for me to stay within and provide feedback. Yeah, those are the big things.
You did a great job, Chris. And I will say to new grads or any clinicians, you don't have to be a podcast host. You don't have to have a YouTube channel. You don't have to have aspirations of getting published in a scientific journal. If you want to do any and all of those things, that's fine. But you can do the same process without any of those things, meaning that you can write up a piece or a one-page handout for patients at your clinic. You can present an in-service to your coworkers. And not only does it benefit you in the learning process and your patients, but it just helps you grow, and you'll get better at that. You'll get better at finding research and maybe presenting it in a more succinct way, where you don't always have to say, oh, does E3 Rehab have a resource for that? That's part of the reason why we do what we do, but maybe we don't discuss some of the nuances or some of the detail that you wanted. Well, that's your opportunity to go search for it yourself and interpret it and present it in a way that feels true to you. Nicole, Chris, anything else to add?
Nope.
No, I think those were both good points.
All right, we'll call it there. Thank you to the Surdyka crew.